Hello, my name is Christos Iosifidis and I am a recently graduated medical student from Barts. Today, we will cover two important topics in urology. First, I will talk about urinary tract infections, and in the other half of the presentation, I am going to talk about urinary calculus disease. So, the learning objectives for the topic of urinary tract infections include Epidemiology and Etiology, Diagnosis, Management, and Prophylaxis. Urinary tract infections, or for short UTIs, are common. They contribute 40% of all hospital infections, with most of the cases being due to indwelling catheters. Generally, females are more likely to suffer a UTI than males, with a ratio of 80 to 20. However, from looking at the table, we can see that male infants are more likely to suffer a UTI compared to female infants. This is due to the greater prevalence of congenital malformations of the urinary tract in the male gender, which increases the risk of a UTI. The most common pathogen that causes UTI is E. coli. They cause up to 95% of all UTIs, with the rest being due to Staphylococcus saprophyticus, Proteus mirabilis, Klebsiella, Enterococci, and others. Factors that increase the risk of having a UTI include sexual intercourse, where enteric bacteria are introduced in the vagina, history of recurrent UTIs, family history, low estrogen levels in postmenopausal women, stasis of urine in males with benign prostatic hyperplasia, and indwelling catheters in the elderly. Diagnosis is initially based on clinical history, with the aim of localizing the source of infection. Lower UTIs involve the bladder and the urethra, while upper UTIs involve the ureters and the kidneys. Localizing the infection is important because upper UTIs require more urgent treatment due to the risk of sepsis. Symptoms that make a UTI more likely are dysuria or pain while urinating, increased frequency, urgency, blood in the urine, and suprapubic pain. Other symptoms include hesitancy and nocturia. Symptoms specific to an upper UTI include back pain, nausea and vomiting, and fever. So a UTI is defined as upper or lower based on symptoms. UTIs can also be defined as complicated or uncomplicated. Complicated UTIs, as the name suggests, include those of anatomical and functional abnormalities such as prostate disorders, renal stones, and vesicoureteral reflux. Other complicated UTIs include upper UTI, UTI in pregnancy, indwelling catheter-related UTI, UTI in patients with immunodeficiencies, and cases where the causing microorganisms are resistant to treatment. Being able to differentiate between complicated and uncomplicated UTIs will help with the choice of treatment. This is because complicated UTI cases tend to be resistant to antibiotics and merit care, and thus more aggressive treatment is needed. This is why taking a thorough clinical history is important. Dipstick urinalysis will help confirm the diagnosis of a UTI. The urine sample should be midstream and clean catch. In children, urine collection pads may be used. The test, although cheap and easy to do, it is neither sensitive nor specific. This means that if the dipstick results are negative, but symptoms are present, the probability of disease is still high. It also means that if the dipstick results are positive, symptoms still need to be present to confirm the diagnosis. Dipstick urinalysis measures nitrites, which indicate presence of bacteria, and leukocyte esterase, which indicates presence of white blood cells in the urine. Following these two results, there are two important scenarios to consider. First, when there is positive bacteriuria but no symptoms. This is defined as asymptomatic bacteriuria, and it is most commonly seen in the elderly. The second scenario is when there are white blood cells found in the urine but still no symptoms. This could indicate a contamination from vaginal secretions or an inflammatory response due to cancer. Another investigation is urine microscopy and culture. This is more sensitive and specific than dipstick, and it can confirm the presence of white blood cells as well as identify the causing pathogen. Urine microscopy and culture is indicated in specific groups of patients. These include complicated UTIs, all males with a UTI because they often tend to have complicated UTIs, patients above 65 years of age, recurrent UTIs, and cases with atypical symptoms such as poor urine flow, abdominal mass, raised creatinine, or infection with pathogens other than E. coli. Imaging is rarely indicated. When done, it is usually either an ultrasound scan or a CT of kidneys, ureter, and bladder. Their purpose is to rule out upper tract abnormalities, stones, hydronephrosis, and renal abscess. Sometimes they are also used for when treatment fails and in recurrent UTIs in males. Another technique is cystoscopy, where the bladder is visualized using endoscopy to rule out tumor, kidney stones, and foreign bodies. In young children with recurrent UTIs, functional abnormality of the urinary tract should be considered and investigated for with avoiding cystourethropy. In this technique, X-rays are used to visualize the child's urethra and bladder and to investigate for vesicoureteral reflux. Looking at the pictures, the top one is a CT scan showing kidney stone, and the bottom picture is an X-ray showing vesicoureteral reflux. Treatment is given once a UTI is diagnosed. This will depend on whether the case is complicated or uncomplicated. The choice of antibiotic will depend on local guidelines, but some general rules apply. In cases where there are no symptoms, but positive bacteriuria is identified on dipstick, the diagnosis of asymptomatic bacteriuria is given. This diagnosis does not require any further treatment unless the patient is pregnant or they are to undergo a urological procedure. If the patient has no anatomical or functional abnormalities and they are non-pregnant with a lower UTI, then this is uncomplicated and treatment is initiated. Antibiotic of choice is either trimethoprim or nitrofurantoin for the duration of 3 to 5 days. For complicated UTIs, urine culture and antimicrobial sensitivity are required, and the choice of treatment should be based on confirmed sensitivities. Longer courses of up to 14 days of oral antibiotics are generally used in contrast to uncomplicated cases. Where there are systemic symptoms of fever, elevated white blood cells, vomiting, and volume depletion, admission and IV antibiotics are required, as well as further investigations. Further investigations may include imaging, renal function, blood pressure measurements, and urine screening for proteinuria. When prescribing antibiotic treatment, pregnancy should always be considered. Trimethoprim should be avoided during pregnancy, and nitrofurantoin avoided at term. Recurrent UTIs are defined as 2 or more episodes in the last 6 months, and they are common in females. Therefore, prophylactic measures are considered. A referral to urology for further imaging investigations is considered if the patient is male, if they have complicated UTI, if there is hematuria or spinal cord disease. Conservative measures are tried with postcoital voiding and front-to-back wiping in women. Postmenopausal women may try estrogens. Finally, prophylactic antibiotics are considered. These may be given in 3 ways. Firstly, standby, where a self-initiated course of antibiotics is given. Secondly, postcoital, for when UTIs are triggered by sexual intercourse. And thirdly, as continuous low-dose antibiotics for 6 months. Moving on to the second section of this presentation, I am now going to talk about urinary calculus disease. The learning objectives are etiology, diagnosis, management, and prevention. Urinary calculi are also known as kidney stones. They are formed by mineral salt deposits in the kidney and then move along the urinary tract to be lodged at 3 anatomical sites: the ureteropelvic junction, ureteral crossing of the iliac vessels, and the ureterovesical junction. There are many factors that predispose to kidney stone formation. Some of the most important and relevant to your exams are increased urinary calcium and oxalate, dehydration, metabolic conditions including hyperparathyroidism, renal tubular acidosis, and cystinuria, Crohn's due to malabsorption of minerals, and chronic use of loop diuretics. Renal tubular acidosis is one of the metabolic conditions causing kidney stones that you should be aware of. Specifically, in type 1, there is inability to secrete H+ ions in the distal tubule, and therefore urine becomes alkaline. Instead of H+ ions, potassium ions are secreted in the distal tubule, and this results in low potassium in the blood. Therefore, the condition causes hyperchloremic, hypokalemic, metabolic acidosis. Most kidney stones have a mixed composition, with the most common crystals being calcium composites. Each type is associated with specific characteristics that help in classifying and for choosing treatment. Specific characteristics to be aware of are calcium phosphate stones and their association with metabolic conditions, uric acid stones and their association with low pH, struvite stones and high pH, and the radiographic appearance of the stones, with most kidney stones being opaque, except uric acid ones, which are radiolucent. Struvite calculi involve the renal pelvis and extend into at least 2 calyces. Uric acid stones are characteristically bright yellow. Patients with kidney stones will present with renal colic. This is severe loin pain that comes and goes, lasting minutes to hours and radiates to the groin. The patient will be unable to stand still due to the pain. The stone may irritate the ureter, and therefore increased urinary frequency and urgency may be presenting symptoms. Kidney stones can be associated with sepsis and urinary tract obstruction, and therefore fever, high heart rate, and hesitancy of micturition would need an urgent urology referral. Investigations can help identify the type of stone and to exclude sepsis. A pregnancy test is required for all young females. This is important because of the exposure to radiation from imaging and also to exclude any ectopic pregnancy masked as a kidney stone. A urinary dipstick can help identify any non-visible hematuria and also to measure the urine pH. High pH would suggest struvite stone. Low pH would suggest uric acid stones. A blood test for use in these and creatinine, including sodium, calcium, and uric acid, will also help identify the type of stone and investigate for two predisposing conditions: hyperparathyroidism and gout. Urgent imaging is then done to confirm the diagnosis and also to exclude other abdominal and pelvic differentials such as the emergency abdominal aortic aneurysm. Non-contrast CT scan is the first line as it is highly sensitive and specific. This means that a negative scan would rule out kidney stone disease. Immediate pain relief is the primary treatment. Recommended analgesic used is a non-steroidal anti-inflammatory such as diclofenac, and the route of administration can be oral, rectal, intramuscular, or intravenous. Paracetamol IV can be given where a non-steroidal anti-inflammatory is ineffective or contraindicated, for example, in impaired renal function or cardiovascular disease. If paracetamol IV is not available, then opiates can be given instead. After initial pain relief, management is focused on the removal of the kidney stone. This will depend on its size and position along the ureter. For stones less than 5 mm in size and found higher in the ureter, management can be expectant as the stone can spontaneously pass within 4 weeks. If the stone is found in the lower ureter and is less than 10 mm in size, then medical expulsive therapy can be tried. Tamsulosin, an alpha blocker, can relax the muscles of the lower ureter and therefore it can lead to stone removal. Watchful waiting and medical expulsive therapy are successful 95% of all the times. If the stone is more than 10 mm in size, or watchful and waiting and medical expulsive therapy have failed, then various procedures may be indicated. Most common and least invasive intervention is extracorporeal shock wave lithotripsy. In this outpatient procedure, a shock wave is used to break up the stone. Although it is the least invasive, the shock wave needs as much exposure to the stone as possible, and it can also cause internal damage, and therefore it has several contraindications. These include pregnancy, severe obesity, abdominal aortic aneurysm, uncontrolled hypertension, and blood coagulation disorders. Where lithotripsy is contraindicated, for example when the patient is pregnant, ureteroscopy can be performed. In this procedure, a camera is passed through the urethra and into the ureter or kidney. Laser beams are then used to fragment the stone and allow it to pass. This procedure is more successful than lithotripsy, but has higher rate of complications due to the invasiveness of the procedure. For stones that are more than 20 mm in size and found in the kidney, or where there is complex renal anatomy, such as horseshoe kidney, percutaneous nephrolithotomy is performed. In this procedure, an incision is made at the flank to get access to the kidney. A nephroscope is then used to locate and remove the stone. Staghorn stones are removed with this procedure. When there are complications, including obstruction, AKI, or sepsis, as well as severe unmanageable pain, then immediate renal decompression should be performed. There are two ways to do this. A ureteric stent can be placed past the obstruction at the ureter, or a percutaneous nephrostomy tube can be connected to the kidney to allow drainage. I have included this table here as a summary of all the treatment choices and their indications. After treatment, and once the stone has been successfully removed, 24-hour urine collection can be performed in specified situations to help determine the underlying cause and thus prevent any recurrent kidney stones. The indications include recurrent or bilateral stones, inflammatory bowel disease, history of bowel surgery or malabsorption, suspected metabolic disease, gout, and if the patient is a child. After one episode of renal stones, there is 50% chance of recurrence without any diet modifications. Therefore, preventative measures are important. Specifically, dietary changes. Adequate water intake will increase the urine flow. Sodium intake should be reduced to maintain hydration and to prevent excess urinary calcium. Animal protein intake should be reduced to decrease urinary calcium and uric acid and to decrease oxalate absorption by the gut and thus urinary oxalate. Fatty food intake should also be reduced to decrease oxalate in urine. Citrus fruits are recommended to increase citrate and thus inhibit further stone formation. Patients should be aware that calcium in the diet should not be restricted. This is because calcium binds oxalate, and thus if calcium is reduced, then this will lead to more unbound oxalate and thus its higher absorption by the gut. Finally, thiazide diuretics can be used in some cases together with diet modification to reduce urinary calcium and thus further prevent the formation of stones. Please note here that thiazide diuretics are used as a preventative measure and loop diuretics can cause kidney stones. And with this final slide, we have reached the end of this presentation. That is all you need to know about urinary tract infections and urinary calculus disease for Year 3 exams. Things that we haven't covered but are still important for exam purposes are anatomy and histology of the kidney and the ureters, side effects of medication mentioned, and the disease profile of primary hyperparathyroidism. Thank you for your attention.